That's the way I feel on
You want to trade?
only because I was on the first year and Donovan and Sterling were at the second. But
You need to run.
I love it.
Well, Caroline will. She'll be here. Oh, no, you're good. You're good. Executive director. I just got it.
I saw that. I was watching the stream.
You're taking, I mean, you're obviously taking. That's you. That's your place.
No, this is you. We're waiting for you.
That's this one.
Wow, all this stuff.
Okay, there you go.
Yeah, it's sad.
They wanted to, that's what they thought. Now we got.
How do you upload what you're recording there?
It's through this online app called, I think it's Livestream or Slack. So we automatically just like use iPhones for it and connect it and go live, and it's really easy.
You take that back onto your laptop and see.
Not through my laptop. It's automatically
Welcome
uploaded.
to the Senate Education Health Committee's Subcommittee on Health Professions, co-chaired by Senator Dr. Siobhan Donovan and myself. We've got a few members missing, but we have quorum, and so I guess we'll start with roll call. Everyone heard the clerk declare we have a quorum. So the first two bills we're going to take up, they're very similar in nature, is Senator Barbara Favola, Senate Bill 1124, and Senator Chapin, Senate Bill 1221, and we'll take them up in a block. There's a lot of folks that would still like to discuss this some more, and is there a motion to take those by for the week? Is that's the patron's preference?
Yes, sir.
As many as favor that motion will vote aye.
Aye.
As many as oppose will vote no. And on a 4-0 vote, those bills are taken by for the week. And next week, we're going to hear those bills. So if you have strong thoughts on them, you need to talk to folks this week about them. And then we've got another bill from Senator Chapin. That's Senate Bill 1167.
Yes, Mr. Chairman. So Senate Bill 11, as you know, we've made significant progress in the last couple of years with regard to opioid issues that our Commonwealth is confronted with. And this is another bill that seeks to move the dial in that regard. Under this legislation, the provider would be prohibited from requiring or requesting cash payment from Medicaid for Medicaid patients, regardless of whether they participate in Medicaid or not. And the thought here is that this will drive Medicaid patients to providers that do take Medicaid, and drive providers who don't accept Medicaid to sign up. This is a similar bill to a bill that was that we saw that had been passed in West Virginia in 2016, and according to their medical director, David Hall, has made significant progress in shutting down their Suboxone cash clinics because they were no longer allowed to charge Medicaid members cash for Medicaid-assisted treatment. So people who are patients in these scenarios, in these situations, are able to keep their cash and gain access to quality treatment from high standard providers. That's what this bill seeks to do.
Thank you, Senator Chapin. Is there any questions from the committee to start out? We are on Senator Chapin, Senate Bill 1167. Any questions from the committee? Are there any folks in the audience who have concerns about this legislation? Think maybe we ought not do this, or think that maybe we ought to do it in a different way?
Mr. Chairman, I meant to offer this, and I would ask that we offer it at this time. There is an amendment, that we'd like to offer. It's in the nature of a notice. There'll be two notices.
You want to report the amendment real quick, just so everyone in the audience knows what it says?
Thank you, Mr. Chairman, Senator Chafin. Amendment, 3 amendments, beginning in line 13, insert A, on line 20, after services, insert board's contractor, so that would be a written denial of reimbursement for such service from GMAS or its contractor. And then after line 21, insert B, which is every provider who provides healthcare services described in subsection A to a patient who is a recipient of medical assistance services pursuant to the state plan for medical assistance shall provide notice to such patient that 1, the Commonwealth's program for medical assistance services covers the healthcare services described in subsection A, and the Department of Medical Assistance Services will pay for such healthcare services, and 2, provider does not participate in the Commonwealth's program of medical assistance and will not accept payment from the Department of Medical Assistance Services for such healthcare services. Such notice and the patient's acknowledgement of such notice shall be documented in the patient's medical record.
And I think I was hearing a motion to move adoption of these 3 amendments.
Yes.
And a second. As many as favor adoption of these amendments, vote aye.
Aye.
Opposed, will vote no. Those are adopted. 4-0. We are reviewing the just amended Senate Bill 1167. This is the first bill we're on. So is there anyone that has any concerns about the bill now as it's amended?
Hi, Becky Bowers, I'm here with the Virginia Association of Community Services Boards. We had some concerns, and I'm not sure that this is taken care of in this, and that would be if the community services boards administering the arts program, for example, if that would mean that all CSBs would have to contract with all the 6 providers in all the regions of the state, we think, in order for them to get reimbursed for these services. And so there was some concern if the person is not, and if the provider is not part of the contract with the CSB, then that might cause them not to be reimbursed. And I think that that's what the notice subsection 2 of the notice means, but it could lead to non-payment. It's just a hypothetical that we've been kind of throwing around in our minds, and we have no alternative language to offer. I don't know if Senator Chapin wanted to respond to that or not, so we can kind of move forward.
Senator Donovan.
Why would the CSBs not all be registered with our providers?
Yeah, and I don't have all the answers to that, Senator Donovan. It was a question that came up in the course of our discussion, and we can continue to discuss it then as this moves forward.
I think that might be a good unintended consequence of the bill, because if we're gonna be providing our arts programs at the CSBs, we need to make sure that they're compliant with those best practices that we've established through the MCOs. So we would want all of our CSBs to be registered with all of our MCO providers with DMAS.
And we certainly support the notion that everybody needs to not be charged for the fees for the medication, so they can stay on the medication. So anyway, I'll take that back, and we'll just kind of continue to mull that one over. Thank you.
Thank you.
All right, thank you.
So Kate Newhausen, the DMAS Chief Medical Officer. The governor does support this bill as amended. From a DMAS perspective, we view it as really important because we do have an issue we hear from providers and plans with cash clinics in the far Southwest. We view this bill as an important change to support our members and allow them to ensure that they're receiving high quality addiction treatment. And from a DMAS perspective, we have asked the CSBs, all of the community service boards, all 40 are credentialed with all 6 Medicaid health plans at this point, just like all federally qualified health centers are credentialed with all 6 Medicaid health plans, which we view as very appropriate and necessary for all safety net providers to be enrolled with our health plans. especially because the arts program does pay average commercial rates, so our providers can take good care and provide high quality care. So our perspective is all SafeNet providers should be credentialed with all plans, and that Medicaid members should be charged cash by any provider, public or private. Thank you.
Thank you.
Good morning, Mr. Chair, members of the subcommittee. Jill Henkin from the Virginia Poverty Law Center. Absolutely support the intent of this bill, and I discussed it with Senator Chapin yesterday. There's a principle in Medicaid that says when a provider serves a patient as a Medicaid patient, even if reimbursement's denied, they can't then bill the Medicaid patient. Medicaid is is considered payment in full, even if the amount that's paid is zero. So I'm just confused about on lines 19 and 20, when there would be a situation that if there's been a rejection of a submitted claim or a written denial of reimbursement for such service, under that Medicaid principle of Medicaid being payment in full, the provider still should not be able to get paid by the patient for those services. So and it's different if there's a rejection of prior authorization, because in that case there hasn't been a service provided. But once a service is provided and a claim is filed, under no circumstances should a provider be able to bill the Medicaid patient. So those are two phrases that I think would improve the bill if we just eliminated the phrases on 19 and 20, a rejection of a submitted claim or a written denial of reimbursement for such service. So it would make clearer that even in that situation, the provider can't ask the patient for help.
Thank you. We just heard from DMAS a minute ago. Would they like to comment on that at all?
So again, from a DMAS perspective, this is happening in the far Southwest. We hear from providers and health plans that there are a number of pill mills and cash clinics. I've had GAP and Medicaid members come up to me and say, I had no idea that Medicaid would pay for my Suboxone. I've had this clinic, this doctor charging me $100 a week, and we had a member lose her house. So from our perspective, that denial of the claim is important because this is exactly what West Virginia did, and that was so effective. So again, I think we have the same intention, and we view this bill as very tightly written to really enforce the letter, to enforce and to ensure that these providers actually try and bill the plans and DMAS, and actually provide counseling that members could be going to other providers and having these services paid for.
Thank you.
So we support the bill as written with the amendment.
So just for clarity, I think what I understand is that there's a loophole if we leave the language the way that it is, because they shouldn't be charging cash even if they have they have zero payment or something else. And so I don't know if there's a difference between West Virginia if we harvested the language, but if it's already not allowable to balance bill, then I'm not sure that we want to give them permissibility that that's an out if you refuse them. I think that's what I understand the issue is.
And if I might add, it's confusing. The amendment talks about a provider who's not a Medicaid provider. That amendment only is so when would that person even file a bill? I mean,
Well,
file a
they're
claim.
charging cash, that's.
Right.
Right.
So that also makes that language that I pointed out just non-applicable, because they're not in a position to file a claim.
So we need to see the amendment, and I know Sarah Stanton had weighed in on this, so again, I would encourage Jill to bring the amendment, of course, to the patrons, and DMAS would be happy to review any language. We support a bill that is as strong as possible to protect our members.
And I do support this concept. I just wanna make sure we're not giving permission to providers to bill Medicaid patients.
All right, thank you. Thank you both.
Mr. Chairman, members of the subcommittee, I'm Nicole Fever, I represent Acadia Health, or provider of substance abuse treatment in Southwest Virginia. We support the bill in concept. I haven't seen the actual amendment, so I can't weigh in on that piece, but in concept, we support the bill. Well, there we go.
All right, is there anyone else that would like to speak on this bill? All right,
I do.
all right.
I'm Doug Gray on behalf of the Virginia Association of Health Plans. We represent all of the Medicaid managed care plans, and we're very supportive of this approach, and we're really pleased that it's actually getting serious consideration. We've been talking about this for 3 years now, and we've been told in the past that we really can't get to it. But then West Virginia showed that they could, and I think that's giving everybody a little more encouragement that we actually could. And this is like mud flowing downhill. People work a way around it and under it and over it. But this will close off at least one part of it. But I mean, there's a lot of different versions of trying to use the Medicaid benefit with people who aren't really Medicaid providers. And that's part of the challenge here. So thank you for giving it up.
All right, so if there's not anyone else that'd like to speak, Senator Barker.
On the amendment here, I'm confused. The amendment, on the insertion of paragraph B after line 21 says that the notice is given to the patient that DMAS covers the healthcare services and that DMAS will pay for them. And then says that provide notice that the provider does not participate in the Commonwealth's program of medical assistance and will not accept payment. It seems to me that there are providers who are in that category, but there are also a lot of providers who do accept Medicaid. So why would we be stating that the provider doesn't accept Medicaid when they do?
Senator Chafin, would you like to respond?
Senator Barker, Mr. Chairman, I would say that this amendment has to be read in context with and inserted into obviously into the original deal. So the amendment seeks to provide notices to those individuals who are not participating in the DMAS program.
Correct me if I'm wrong, but I think this is an issue of this is happening.
Right.
And by
Yeah, I understand.
including that language.
I don't think the language is what we want. I don't think the language is what you're intending to try to be able to convey here. Because we don't say that if they don't participate, then this is what they do. We just basically say this is what they say, and that would not be correct in many situations.
Well, let's see what council has to say.
Mr. Chairman, Senator Barker, I think Senator Barker is correct. You should probably read every provider who provides healthcare services to prescribe in subsection A and who does not accept payment from DMAS.
Yeah, that would clarify, I think. Yeah, that would clarify, yeah.
So we've got the amended bill before us. Would Senator Barker like to move the amendment as just explained by council?
I would certainly be happy to do so. I move that amendment, so.
And there's adequate support. Does everyone understand that the amendment that was just read? Did everyone hear what council said? All right, as many as favor the motion of adoption of the amendment will vote aye. Aye. As many as opposed will vote no. And by a 5-0 vote, the amendment's adopted. So, yeah, we now have a multiple time amended bill, but council's on top of it. And we've got that bill before us. Is there any, first I'd like a motion, and then we can have discussion.
Second.
So we've got the motion with adequate support to recommend that the full committee report the bill to the full Senate. Is there any discussion on that? We feel like we're in a good place with it. So thank you for everyone going with this. As many as favored the motion will vote aye.
Aye.
Many as opposed it will vote no. And on a 5-0 vote, it's recommended for report. So unless something changes between now and then, you do not need to worry about coming to Senate Education and Health on Thursday.
Mr. Chairman, I think we want to verify that language that we were talking about denied payments is just cleared up between DMAS and how it's perceived before the committee. So there may be one more amendment if that indeed is a challenge.
I think you're pretty good place though, so.
Thank you.
And council will get you the amended version. Thank you very much, Senator Chafin. who's next on our list? Senator Dance, Senate Bill 1405.
Senate Bill 1405, request response from the Commission on Healthcare. The intent of this bill is to encourage pharmacists to counsel patients on the importance of appropriate drug disposal. The existing code requires pharmacists to offer counseling to patients within a prescription guidelines, but proper storage of drugs is currently listed as one of the suggested topics for counseling. This bill adds proper disposal to that list. The bill is permissive in nature in that it does not require pharmacists to provide counseling on proper drug disposal if the pharmacist does not deem it necessary to cover that topic, or if the patient does not wish to receive counseling at all. This bill is motivated by research indicating that the vast majority of patients inappropriately store or dispose of unused drugs, despite increasing availability of drug disposal sites in pharmacies and law enforcement agencies in the Commonwealth, as well as other disposal options such as mail-back and local developments. I would also note that this bill does not apply to drugs dispensed in an inpatient setting, such as a hospital or nursing home. There are numerous health risks incurred by inappropriately stored or improperly disposed of unused medicine, including drug diversion and appropriate use and poisoning. In addition, improper disposal of medicine results in the presence of active pharmaceutical ingredients in waterways. Nationally, fewer than 10% of individuals consider use of appropriate drug disposal methods recommended by the FDA. Just gonna do it. And currently in Virginia, approximately 160 pharmacies and 65 law enforcement agency locations are authorized to take back drugs from patients for appropriate disposal. What these numbers show is that there is a need to educate people on the proper methods of drug disposal, and that there is ample capacity for processing disposed drugs. This bill would expand an existing tool used to encourage pharmacists to educate patients and avoid potentially dangerous mishandling of prescription drugs.
Thank you, Senator Dance. I think we almost have a quorum of JCHC here today. So I think we're pretty familiar with the concept. Do we have any questions from the committee? Well, just real quick, is there anyone in the public that's got any concerns about this? I like to see where Senator Barker was taking this. There's a motion before us to recommend a report to the full committee, to advance it to the Senate. Any discussion on Senator Barker's motion? As many as fair, that motion will vote aye.
Aye.
As many as opposed will vote no. And that is recommended for report on a 6-0 vote.
Thank you, Mr. Chair. Do I need to come to the?
You do not need to come to the full committee. If something changes, we'll let you know.
Thank you very much. Senator Edwards has Senate Bill 1289 for us.
Mr. Chairman, members of the committee, Senate Bill 1289 is requested by the administration of the Department of Health Professions and the Board of Pharmacy. What this does is to allow any health regulatory board to consider a summary suspension of a person's license in the event there's evidence that the DEA registration has been suspended or voluntarily surrendered in lieu of disciplinary action. That's the first thing it does. Any regulatory board, health regulatory board, can suspend a license when DEA registration has been suspended. The second thing it does is provide a process for the Board of Pharmacy, which of course oversees pharmaceuticals. And the process is that when this happens, the board must do an inventory of the pharmaceuticals and can put the, place the pharmaceuticals under seal when the license has been suspended. And, after they do the inventory, they should, then, maintain the property, the pharmaceuticals in a secure place, and it would restrict access to these particular pharmaceuticals. It further clarifies that, these pharmaceuticals could be subject to forfeiture if necessary, seizure and destruction. It goes on to say that the controlled substances, if they're abandoned at a location not authorized for storage, that they could be considered contraband. What that means is the board then could seize and destroy the contraband if that's in the situation. And lastly, it provides that any law enforcement officer in coordination with the Department of Health Professions can seize the property, the contraband, and dispose of it. It provides that it allows for the disposal of the drugs and devices after 60 days from the notice of seizure rather than the current 6 months. That's a summary of it, and I have Dr. Caroline Jurin, the Executive Director of the Department of Health, of the Department of the Board of Medicine, of the Board of Pharmacy. There's so many boards here, to explain it much better than I have.
Well, I think you did a great job, Senator Edwards. That's thorough but concise. Before we hear from the subject matter expert, it might be better first, does anyone on the committee have any questions about the bill? And is there anyone in the public that has any concerns about this legislation? So we know who you are, and we know that you support the bill. Is there anything else you think? All right, thank you. That's the best testimony there is. Just a second. All right, any discussion on the motion to recommend reporting by the full committee? Hearing none, as many as favor that vote will vote aye. Many as opposed will vote no. And it's a 6-0 vote to recommend
Mr.
report.
Chairman, I'd like to embrace my other bills as well.
So that exhausts bills from, introduced here today that are outside of the committee. I think Senator Carrico probably has to get moving soon, so we'll direct our attention to Senator Carrico and his Senate Bill 1518.
Thank you, Mr. Chairman, and I'm probably going to make a motion here just as soon as I do the testimony, explain why this bill's here, and meeting with the stakeholders, understand some issues, that unintended consequences of this bill that probably needs for this bill to be taken by for the year, or stricken, whatever we do in this calendar year because of the situation. But the bill's here to try to find and try to direct the Board of Dentistry and doctors to try to find non-pharmaceutical ways in therapy to prevent opioid addictions, and basically giving them direction that they'll look and they'll direct and they'll interview and discuss with their patients the dangers of those opioids, the addictions that occur from those opioids, and find other ways to prescribe other medicines that are not addictive, and therapies in which they can manage and deal with the pain that they have. However, meeting with the insurance companies earlier, and looking at the section in the beginning of this bill, the way that the bill is written, it could require insurance companies to pay for over-the-counter drugs for therapies that we are not sure are proven therapeutic ways to do things. And I think that that complicates the bill to the point where I wouldn't feel comfortable putting this committee in a posture in which we would be sending something out to the full committee that may be very likely that nobody would wanna support. The other part is, the regulations that I've seen thus far recommend doctors do this, but it doesn't, direct them to, and I think, you know, we can get through this part through regulatory measures. And, you know, I think this is something doctors need to take more, and there's a doctor on this panel, direction in trying to make sure that the patient's finding out if they have that addictive nature. As you know, we deal with these opioid, crisis all the time, not just for Southwest Virginia, but all over Virginia. So I think we gotta find new ways that we, try to deal with these, patients. And, someone who's been prescribed opioids, I know how easy it is to get them. So I'm just trying to find a way to avoid, the ability to get those, drugs and be able to, get them into the hands of people that are addicted. So with that being said, I'm just gonna ask this committee to either, strike the bill or lay it on the table, because there's still a lot of things that we would have to work out, trying to get it in a posture that we don't have unintended consequences with other agencies or other, entities with insurance companies and doctors.
Thank you, Senator Carrico. My preference would be, it sounds like a good concept, it just needs to be worked on, would be to take it by for the year, but I don't think that's available to us in the second year of a General Assembly.
None of us know whether we're gonna be back here or not.
So, I would just suggest that folks, you know, get with Senator Carrico and help him work on this idea, cause it's something that we ought to keep pushing. I think that the best course of action we have available to us under the rules is to recommend striking the bill at the request of the patron.
And I'd so move.
And it's been moved by the patron, second. Does May support that motion, vote aye.
Aye.
And so that will be a 6-0 recommendation, to the full committee. And encourage folks to talk with Senator Carrico about how we can keep working on that, issue. I believe our final bill today is Senate Bill 1209, from Senator Peake. So please give him your attention.
Thank you, Mr. Chairman. Senate Bill 1209, we're attempting to amend the definition of podiatrist and physician assistant. This will allow PAs to work as a part of a multidisciplinary team of providers with a physician or podiatrist to provide ongoing collaboration, consultation under a practice agreement. This is not a bill that's trying to gain independent practice for PAs. The Virginia Association of PAs has worked on this legislation, and the Medical Society of Virginia supports it. So we're just trying to make it easier for physicians assistants to work in a team setting. And I have invited Scott Johnson to come up here and tell you why I crafted this bill, if there are any questions.
All right. First, let's see, is there any questions from the committee about what this bill might be trying to do? So I think everyone's got a good understanding of it. Is there anyone in the audience that has?
We have a substitute version.
Move the substitute.
All right, the substitute has been, moved properly. Spain's favor adoption of substitute will signify by voting aye.
Aye.
All right, so we're just gonna pause for a second to look at the substitute. Is there anything that you want to draw attention to in the substitute being different, Senator Peake?
I am. What is different in the substitute, Scott?
Mr. Chairman, members of the committee, Scott Johnson, General Counsel for the Medical Society of Virginia. The first difference in the substitute is the Board of Medicine requested a second enactment clause to promulgate regs, so that's at the very tail end of the bill. The next thing that is different from the introduced bill is the emergency room physicians and the PAs work together to remove some outdated language in there. Our PAs, today they're supervised by a physician or podiatrist. For those working in emergency rooms, they have some very specific language that was set forth in there, and I will just draw your attention to line 250 that rolls on over to page 11 as well. most of that deleted language came from the ER docs working with the PAs to say, it doesn't need to be in statute, we put it in the practice agreement, and that's the place that it ought to be, as well. We've been working, with the PAs since the fall of 2017. Senator Peake is correct that they clearly said they don't want independent practice, and this is not independent practice. They're practicing as part of a team so they can better access care. With me today is Jeremy Welsh, from the PA Association up in Lynchburg. He'd like to, say a word or two, if you could, please.
Yeah, let's see if we've got any folks with concerns, so then you can address those and your remarks on why you don't share those concerns. Does anyone have any concerns about the bill? If you don't, we're about to go forward, so if you got concerns, come up right now.
Don't have a concern, just, and I don't know if you just explained this, I couldn't hear back there, but on page 14, you're dealing with nurse practitioners. And I represent nurse practitioners, Richard Grossman.
Mr. Chairman, I would answer Mr. Grossman's question that on page 14, the two definitions in there from line 354 through 364, Mr. Stevens relocated those in the general definition section on line 29 through 38. So it was relocated.
That appears to be the case, just as he said. Thank you for that quick answer. That's just like President Reagan. So, does anyone else have anything they feel that concerns? I think the bill's in pretty good posture, so if you just wanted to give a small push.
Sure. Thank you, Subcommittee Chairman, Senator Peake. I'm Jeremy Welch, I'm a PA, and I represent Virginia Academy PAs. We support the bill, we work closely with MSB to get it to where it is, and we feel that it strengthens our relationship with our partner physicians.
Thank you. So is there a motion? We've got the motion before us to recommend the full Senate Education Health Committee report the substitute for this bill to the full Senate. Is there any debate or comments on that motion? As many as favor that motion, vote aye.
Aye.
As many as opposed, vote no. And on a 6-0 vote, that's recommended for report. And that concludes today's calendar. Because it's a short session, bills aren't gonna go by next week. If they're on the docket next week, they will be heard. And those two telemedicine bills, folks should get with Senators Chapin and Senator Bull and any subcommittee members if you've got strong thoughts about it, because that will definitely be heard.